It is the top of the hour, 12:01. You are at Providence Grand Rounds, special session. Today we're going to cover ambulatory treatments for COVID-19 by Dr. George Diaz. This is some basic housekeeping information to start. Go ahead and go to the next slide. All the attendees are muted in this environment. We ask that if you have questions, please use the Q&A box. We will see those throughout the meeting, and we will ask Dr. Diaz as the presentation is nearing its end. And we are recording this presentation, and it will be posted on the Caregiver Grand Rounds site afterwards. You can also view previous Grand Rounds there. As far as CME goes, you can claim your CME by using the data on this slide. And next slide. There is a disclosure. So Dr. Diaz has reported that he is speaker for Gilead. All other disclosures are not relevant at this moment. And with that, I would like to introduce Dr. Diaz. Dr. Diaz, as we all know, has an illustrious career. After graduating from the University of Washington for his undergraduate degree and Oklahoma Medical School, he did his residency training and a year as chief resident at Utah before returning to UW for his ID fellowship. He is presently a clinical assistant professor at Washington State University College of Medicine and has lectured and published podcasts both domestically and internationally. He has a long list of publications. He continues to be engaged in a variety of active research projects, and he earned no small level of notoriety with his role in helping to manage the very first ever COVID patient in the US. So please join me as we welcome our very own international superstar, Dr. George Diaz.
Thank you so much, Dr. Weiss. Thank you to the Grand Rounds Committee for inviting me to participate in this Grand Rounds. We're actually now, I think, 8 days short of 2 years from the very first patient that presented in the US with COVID. As many of you know, we are currently under a pretty large surge with Omicron. As we look back, it's been a pretty rough 2 years for all of us, and all of the caregivers that have been caring for patients over the past 2 years have been heroic and are heroes now. I'd like to thank you for your service to our health system and to our patients, because you've made the lives of our patients better with your work over the last couple of years. What we're going to talk about today is the newer ambulatory treatments that we have available for COVID. There are a number of treatments that we have available for inpatients, and we also have very good vaccines that are available. The purpose of this discussion will be to review the literature surrounding the currently recommended available treatments for ambulatory COVID-19. We'll review current guidelines for treatment, and then we'll also take a look and see how these treatments should be ordered in EPIC. Next slide. So here's a cell wall or a cell that's being infected by COVID. And there are a number of targets now that we have in the ambulatory setting. Next slide. The first here are the polymerase inhibitors, and we'll be discussing remdesivir and molnupiravir. These block the RNA polymerase of COVID-19 to prevent replication. Next slide. The next category are protease inhibitors. There's a single agent now that's available called Paxil. This protease inhibitor prevents the cleavage of COVID-19 proteins to prevent their activity. Next slide. And then lastly, we will also be discussing anti-spike monoclonal antibodies. And these are antibodies that are available that bind COVID-19 even before they infect a cell or after the virus infects a cell and releases virus. These antibodies will bind COVID-19 and remove them. Currently, we have a single monoclonal antibody that has activity against COVID-19, or the Omicron variant, I should say. There are a couple of other monoclonal antibodies that have been approved previously, but unfortunately, sotrovimab is the only monoclonal antibody that retains activity against Omicron at this point. Next slide. So we'll take a look at the major study for use of Sotrovimab in people with mild and moderate COVID-19. Next slide. So this study is fairly typical. Many of these patients were actually in the US. And if you look at the baseline characteristics of this study, it was done in people who had mild to moderate COVID-19, meaning basically none of them had or should have had hypoxemia at the time that they were treated. In addition, it should also be noted that patients generally had symptoms of shorter duration. On average, 57% of the patients had symptoms days 3 or less, and 42% had symptoms for 4 or 5 days. Once you get past about 7 days, the ability of this antibody to work substantially decreases. And so really, it's recommended that this treatment really not start past about 7 days at most, and the earlier is the better, which is the case for all of these treatments. The earlier they can be started after symptoms begin is better. In this study, the average age of the patients was 53, 46% were male, 63% were Hispanic, which is a large portion of Hispanic patients. 63% had a BMI over 30, and 89% of the patients had 2 risk factors for COVID-19 progression. And as you can see, the typical risk factors are noted in the table here of age, diabetes, obesity, kidney disease, heart disease, COPD, and asthma. But if you look at the patients that were included, by far and away, the most patients were in the age over 55, diabetes and obesity. The other risk factors were much smaller in representation of overall patient population. Overall, these two study populations between Sotrovimab and placebo were quite well balanced overall. Next slide. So here are the key findings, and the primary outcome for essentially all of these studies is hospitalization and death. Although really hospitalization is the key primary outcome, because there should not be many deaths in patients who have mild to moderate disease. And when you look at the absolute reduction in hospitalization in the arm with Sotrovimab, it was only 1% hospitalization versus 7% in the patients that got placebo. And as one would expect in the US, in the Sotrovimab arm, there were no deaths, and there was only 1 death in the placebo arm. So relatively low mortality overall in both cohorts. When you look at the relative low risk reduction of hospitalization in the study population, it was 85%. Next slide. In terms of adverse events, the only adverse event that occurred in more than 1% of patients with study drug was diarrhea, 6 versus 3 in the placebo group. There were infusion-related reactions that was 1% in each arm, and in the arm with Sotrovimab, there was only 1 case of dyspnea that was attributed to Sotrovimab. The serious adverse effects were essentially limited to hospitalization for COVID-19. And of the people that were hospitalized, none of them were felt to be related to Sotrovimab. And when they did lab testing between both study drug and placebo, all the sort of laboratory parameters were essentially the same. This drug does require an infusion of drug over 1 hour and then a 1-hour observation period afterwards. So generally, a very, very well tolerated drug overall, with relatively little in the way of adverse effects. The major drawback is that it is an infusion requiring an IV and at least 2 hours of patient being in a chair or being observed after the infusion. Next slide. So we'll talk about the protease inhibitors now, and there's really only one, and it's Paxil. So the COVID-19 has 2 main protease inhibitors, one called Mpro and one called PLpro. Mpro is smaller, it's easier to produce and study, And so this protease will begin processing translated mRNA that's protein now. And when MPRO cleaves these proteins, they become activated and participate in usual protein processes with COVID-19. What these protease inhibitors do is basically prevent MPRO from being able to cleave the protein, and then these long uncleaved protein is not able to fold correctly and become active to propagate infection. Next slide. So Paxil is the protease inhibitor that's currently available. It's a combination of two drugs, nirmatrelvir plus low-dose ritonavir. Its target is MPRO. The dosing is twice daily for 5 days, and it's only been studied so far in non-hospitalized patients. Next slide. So the main study is EPIC-HR. It's a phase 2/3 study that was granted an FDA emergency use authorization December 22nd of last year. The study design was non-hospitalized patients in a 1-to-1 ratio between receiving either Paxil twice daily for 5 days versus placebo. The inclusion criteria were people that were age 18 or over, and they also had to have a positive COVID test as well as symptoms, with symptoms of less than 5 days. They needed to be mild to moderate disease, and they also, similar to the study with the monoclonal antibody, they had to have at least one or more condition that predisposed people to severe disease. These patients were also unvaccinated. The primary endpoint, like with the monoclonal antibodies, was a COVID-19 hospitalization or death at day 28. Next slide. So the study population, they had 2,200 subjects that were randomized. The mean age was 46 years of age, 51% were male, 72% were white, and then a smattering of other races. 45% were of Hispanic ethnicity. 66% of the patients had symptoms of less or equal to 3 days at the time of initiation of the study, and 47% were serologically negative at baseline. They also measured viral loads, and then the patients that were also screened to receive a monoclonal antibody were excluded from the study, since they also would have received an antibody that could have confounded the study. The study and population was balanced well between study drug and placebo. Next slide. So here are the results, and this comes from the FDA EUA. So the hospitalization in patients who got Paxil was a total of 8 patients out of 1,000, representing 0.8% of patients who got Paxil versus 6.3% and 66 patients who got placebo. All-cause mortality through day 28 was 0 in the Paxil arm, and in the placebo arm, there were 12 deaths. The relative risk reduction for Paxil to reduce hospitalization or death was 88%. There were over 300 sites, all over the world. And so far, we have not yet heard exactly which sites contributed to all these patients. So it's unclear why there were so many deaths in the placebo arm, which would not normally be expected. Next slide. So here are the subgroup analysis for these patients, and you can see across all of the risk factors, there was generally a benefit. If whether or not the symptoms were less than or equal to 3 days were about the same. People that were over 60 years of age had the highest benefit. And then as you scroll down there, you can see that all the usual risk factors all had benefit: BMI, diabetes. If the baseline serology was negative, that was a positive finding, and it became sort of less effective if patients were already seropositive. And this generally tends to be the case for many of these antivirals or early treatments, that once people begin making their own antibodies, the monoclonals become less effective, and it's likely the case also for the other antivirals, meaning that probably at that point the patient has already had symptoms long enough that that removing virus probably has diminishing benefit. The next slide. The adverse reactions were relatively minimal. Of those that occurred over 1%, greater than the placebo arm were dysgeusia, 6% and less than 1% for placebo, diarrhea 3% versus 2%, hypertension 1% versus less than 1%, and myalgias 1% versus less than 1%. The number of people who discontinued treatment due to an adverse event was 2% in Paxil and 4% in the placebo. So generally these were relatively mild, and most patients did not need to stop treatment because of any side effect, which were relatively minimal. Next slide. So now we'll move on to remdesivir. Remdesivir has been around. Actually, we used remdesivir on the very first patient in the US. So we've got experience of about 2 years with this drug now. It's an adenosine analog, and it causes delayed termination. As you can see in the middle graph there, that remdesivir is transcribed and added, and it causes delayed termination, chain termination. So the MRI cannot be completed, and viral replication sort of ends. The dose for remdesivir is similar to the inpatient dosing, which is 200 milligrams intravenously times 1, and then you get 100 milligrams daily for 3 days. Generally well tolerated, and remdesivir is already FDA approved and on IDS-NH guidelines for treatment of inpatients. Next slide. We're going to review here the use of early remdesivir to prevent progression to severe COVID-19 in outpatients. This is the Pine Tree study sponsored by Gilead. Next slide. So similar to the other studies, 3 days of remdesivir versus placebo. These are also going to be high-risk patients. The patients were, the inclusions were 12 and over with a risk factor or greater than age 60. Patients had to have a positive COVID test within the last 4 days and symptoms of 7 days or less. They were excluded if they were vaccinated, and they were also excluded if they received a monoclonal antibody. And the primary endpoint, like the other studies, was COVID-19 hospitalization or death at day 28. Next slide. Most of these patients were enrolled in the US, so 94% of the study population was in the US. The average age of the participants was 50, 47% female, 81% white, and of those, 44% were Hispanic. The mean duration of symptoms for the study population was 5 days. BMI over 30 was 55%. And notably, there were really only 3 patients that were less than the age of 18. So this is primarily a study in adults. But overall, the baseline characteristics in the patients in study group and placebo were well balanced. Next slide. Again, the key finding is reduction of hospitalization or death, and the relative risk reduction here for remdesivir was 87%. The exact percentages was 0.7% in the remdesivir arm versus 5.3% in the placebo arm. And as one would expect in the US, there were no deaths in either the placebo arm or the remdesivir arm. Also notably, which I didn't add in text, was that they could not detect a reduction in viral load in the remdesivir arm. Next slide. Similar to the other drugs, these are generally well tolerated. The only adverse events that were greater than placebo were nausea, 10.8 versus 7.4% in study drug versus placebo, ageusia 2.9% versus 2.5%, anosmia 3.2 versus 2.1%. And again, there were no deaths noted in either arm. So generally very well tolerated. This drug usually requires a 30-minute infusion, and there's no post-infusion observation period. Next slide. So here we'll talk about another protease inhibitor called molnupiravir. It's a cytidine analog of a prodrug called NHC. This is a really interesting drug because its mechanism of action is it induces viral error catastrophe. So it basically causes the polymerase to begin misplacing nucleic acids that result in a catastrophe to the viral replication, so that it can no longer replicate itself. So it basically induces massive errors. The FDA granted an emergency authorization for this drug on December 23rd. Next slide. Some of the major concerns with a drug that causes mostly severe errors in viral replication is that it could have off-target concerns. They've looked at bone and cartilage toxicity in patients less than 18. That hasn't been seen. There's concern about possible embryo-fetal toxicity, especially in pregnancy. There have been studies looking at mutagenicity in vitro, which has been seen, but in vivo, it has not been seen. The FDA has concluded that there's a relatively low risk of mutagenesis given the short duration of treatment. There's also concern about viral escape, meaning that if you cause a lot of errors in a virus, that you could potentially generate new mutants or variants that could then be a cause for other variants of concern. This is a theoretical risk. Question's not fully answered. Next slide. So in terms of the off-target effects, there have been the RNA DNA precursors share a common intermediate step, and in vitro exposure may be mutagenic to host DNA during host DNA replication. If you look at Merck data, they looked in vivo rodent models. They did not increase the mutation rates. They looked at in vivo rat micronucleus. There was no chromosomal damage that was seen, and the conclusion was that there was low risk for genotoxicity and mutagenicity. Next slide. Other studies looked at escalating doses in animals. At 2 times the recommended human dose, there was no effect on fertility. However, in rats, there was embryo-fetal development issues when the doses were higher. So at 8 times recommended human dose, there were issues in rat development, including malformations of the eye, kidney, axial skeleton, and rib variations. At 2.9 times recommended human dose, there was a decrease in fetal body weight and delayed ossification. But if you got down to nearly normal recommended human dose, there were no developmental toxicities noted. In terms of maternal rat toxicity, at 2.9 to 8 times recommended human doses, there was weight loss and decreased food consumption. And in rabbits, in terms of embryo-fetal development, 18 times recommended human dose caused reduced fetal body weight. At 7 times recommended human dose, there was no toxicity. And then the maternal rabbit toxicity at 18 times recommended human dose, these rats had reduced food consumption, body weight, and there was also abnormal fecal output. Next slide. So here's a study reviewing the outcomes for use of molnupiravir for COVID-19 in non-hospitalized patients. Next slide. So similarly, it was among non-hospitalized patients. It was a 1-to-1 study drug versus placebo, where patients got treatment for 5 days. This was a study done in adults, and patients had symptoms of 5 days or less. This was, again, mild to moderate disease, so non-hypoxemic patients. And similar to the other studies, they had to have at least one condition for severe disease, as well as to be unvaccinated. And similarly, the primary endpoint was hospitalization or death at day 29. Notably, greater than 90% of the enrolled subjects were from Latin America, Europe, and Africa. And also the variants that were studied amongst the study populations were quite varied amongst circulating worldwide variants. Next slide. So in terms of baseline characteristics for this study, the median age was 42. So a little bit younger population. Obesity was present in 75% of people, and 32.4% were greater than age 50. The study population, study drug versus placebo arms were balanced. Next slide. So here's the primary efficacy. So there was initially, in the interim analysis on the left, there was roughly a 50% reduction of hospitalization, but after the final analysis, the net difference was 9.7% hospitalization or death in the placebo arm versus 6.8% in the study drug, with a relative risk reduction of 30%. Oddly, there was a difference in deaths across both groups, with 1 death in the molnupiravir group, and again 10 deaths in the placebo arm, which is more than what we would expect in these study populations in the U.S. Next slide. Overall, the drug was well tolerated. In terms of adverse events, over 1%, diarrhea occurred 3%, nausea 2%, dizziness 2%, and headache 1%. So generally well tolerated overall. Next slide. So when we take a look at the guidance, now we have 4 agents that have gotten either an FDA emergency use authorization or have been added to the NIH and IDSA guidelines for off-label use, namely remdesivir. And the NIH has given guidance in terms of what would be considered first line, which they have indicated Paxil because it's oral and has relatively little side effects. Second line, citromavab, because it's equally sort of effective to Paxil, but unfortunately requires an IV. So that's the second line. And third line is remdesivir, with similar efficacy as the first 2, but requires 3 infusions. Fourth line has been noted to be molnupiravir, and this is because of reduced efficacy in terms of reducing hospitalization. Each one of these agents has its own problems, and currently the federal government has purchased Paxil, citromavab, and molnupiravir, and they're distributing it to each state, and each state is then working on distributing it locally to each health system or hospital. Remdesivir is widely available. It would be an off-label use. Currently, there is a outpatient infusion CMS charge code. So we believe it's covered in the outpatient setting, but that has not yet been verified. Next slide. So these, because Paxil is oral and it can be taken at home, it's first line. It's currently in very low supply. It also has significant drug-drug interactions, which we'll discuss as well, that may limit its use in many patients. This drug is free to patients if they are able to obtain it because it's provided by the US government. Similarly, citromavab is also in low supply. There are operational issues with being able to provide these drugs in the outpatient setting because it requires an IV, it requires nursing staff to be able to place the IV, a location where you can do the infusions, but it is a one-time infusion and it requires roughly at least 2 hours of infusion time plus observation. So it can be difficult to operationalize in an outpatient setting, and few sites are able to do this. Thankfully, the drug is free to the patient, so there's no cost because it's purchased by the US government. As mentioned before, remdesivir is third line, and it requires 3 infusions, which is even more difficult to do than citromavab because the patient has to come back 3 times for infusions. And then lastly, molnupiravir is fourth line. It's the least effective and also has limited supply, also free, provided by the US government. Next slide. So other issues are that the FDA EUA criteria are fairly broad, and so they're essentially the inclusion criteria, which means that almost any patient can meet criteria. For example, if their BMI is only 30, for example. There is additional guidance being provided by state departments of health. For example, the state of Washington has provided interim guidance for how to use Paxil, citromavab, and molnupiravir to limit its use to higher risk patients. For example, changing the BMI from 30 to 35 to weed out some of the lower risk patients who have mild moderate disease. There's also guidance that will likely be coming from each of the Providence regions to help limit use. And then there also may be individual ministries that will provide local guidance to try to limit the use of these drugs to the high risk patients. Some ministries may be using the NIH Tier 1, for example, or a variation of that to really try to focus in on the patients that are at highest risk. It should also be noted that we believe that Omicron probably has a roughly half or a third as severe disease, and so fewer people may require hospitalization with Omicron versus prior variants such as Delta, and so that would potentially also affect the number needed to treat, increasing the number you need to treat to prevent one hospitalization. In these studies, most of these drugs required roughly a number needed to treat in the range of about 20 to prevent one hospitalization. Next slide. Here's an example of the guidance that was provided by the Washington State Department of Health to limit the use of these agents when they're in scarcity. And you can see that there's slight differences in the criteria for each one of these drugs, but the general message is that they are really trying to limit and enrich for a population that would benefit the most by these agents. Next slide. So when you want to order these treatments to comply with an emergency use authorization or to use an off-label remdesivir, providers must attest that the patients qualify for an inclusion criteria and none of the exclusion criteria. The providers need to provide the patient with the FDA frequently answered questions sheet and that the patient reviewed them. And the easiest way to accomplish this is to use dot phrases. And we have created dot phrases for each one of these drugs, and you can see them listed there. So dot NIRITUA is the dot phrase for Paxil and so forth. And you can see the dot phrases for each one of these other agents. Next slide. And so here's what the dot phrase will look like in a progress note. You can click F2 to attest through the note. Yes, they meet criteria. Yes, they do not meet the exclusion criteria. And then in blue there on the right, you can see the hyperlinks, and these are ways you can print out the FAQ to provide to the patient or email them if you are doing these visits virtually. And then you sign your note, and then you've completed the required EUA requirements. Next slide. So if you are going to be ordering sotrovimab or remdesivir, these are intravenous drugs. These are difficult to operationalize because of the requirements that they're IV. And so, for example, if we are looking in Snohomish County, for example, with this just north of Seattle, the Providence ED and the Swedish Edmunds ED are able to provide these drugs to the ED. We are working with Providence Medical Group in our county in Mill Creek to hopefully be able to up and running to dose sotrovimab and remdesivir. And locally, the Everett Clinic is also trying to be up and running with sotrovimab. There will need to be communication locally to find out where these treatments are available and what the referral process is to be able to get your patients these agents. Next slide. For the oral treatments that you can order in Epic, the major issue with Paxil is that it has these are protease inhibitors, and so there are many drug-drug interactions with these with this class of drugs. Currently in Epic, it's alerting on ritonavir at the moment, which has most of the interactions, and the current Epic alerts are not complete. And so as part of the meeting invite, you will see an SBAR that was sent by our system pharmacy advising providers about what the issues are with the alerts in Epic. And you can see that some of the alerts that are firing are not ones that, for example, may fire as a medium alert may actually be a contraindication. And so in the attachments that you have as part of this talk, please review the SBAR that will give you which interactions are not currently being fired as we would hope. This drug can also not be used for people with a creatinine less than 30, and the dose is decreased for creatinine clearance of 30 to 60. So what will happen if your patient has renal insufficiency with a clearance of 30 to 60 is that the pharmacist will remove one of the nirmatrelvir tablets and put a sticker over it. So they will only receive the blister packet with the correct number of doses in each packet. So patients should be advised that when they get their packet, one of the tablets will not be there, and that's correct for their creatinine clearance. One can also use the Liverpool checker for manual drug-drug interaction checking, and I listed the website there. It would also be worthwhile to advise the patient that when they are calling or checking to get their prescription, that the pharmacy also has a complete med list on file to make sure that there are no drug-drug interactions that need to be addressed prior to the patient picking up the drug. Next slide. So here's the Paxil order in Epic. And with the two arrows that are pointing down, what I have is hyperlinks. We have added hyperlinks to the order itself that includes also a link to the fact sheet, the COVID-19 clinical guidelines from the health system, and then also a hyperlink to the Liverpool drug-drug action checker. And in the picture on the left, you will see what it will look like for someone that is has normal renal function, that they will be instructed to take a total of 3 tablets twice a day. And on the right, what you will see is what will happen if the patient has renal impairment, and that the patient should take 2 tablets twice a day rather than 3. And this will be included in the order that files electronically to the pharmacy. Next slide. When ordering molnupiravir, this drug is contraindicated in pregnancy. So in the event that we find that there's a positive pregnancy test within the EMR and the order is entered, the provider will see that that there's a BPA that will advise the provider not to order this drug in pregnancy. It should also be noted, however, that women of childbearing age must use birth control during treatment and for 4 days after the last dose of molnupiravir, and men must use birth control during treatment and for 3 months after the last dose, given the unclear nature of the effect of this drug on sperm. Next slide. So how to find if your state has drug available. The number of doses for each state is at this point relatively small. So the entire state of Washington this week has dispensed 1,180 courses of Paxil for a population of about 7 million. And it has received 5,160 courses of molnupiravir. Within my hospital, which is a 600-bed hospital, we have received 20 courses of Paxil and 40 courses of molnupiravir. On the right here is a little map that the Department of Health is putting together to advise providers what pharmacies have received allocation. So there will be a map, and at least within the state of Washington, the allocations to commercial pharmacies will be Albertsons and Safeway, and there will be a map like this so providers can see, which pharmacies have drug. In order to be able to find out whether or not these pharmacies got an allocation of drug. Next slide. The state of Washington is creating a dashboard that will advise providers whether or not these pharmacies received allocation and how many they have on hand. This is not likely going to be a real time where one can see, 20 courses in the morning and then 10 courses in the afternoon. It will likely be a daily tally of whether or not they have courses available. So at least providers will be able to look and see what pharmacies likely have or do not have drug on hand. Each state is responsible for allocating drug across the state, and then hopefully the other states will also provide some sort of guidance in terms of how to find drug once it's been made available to pharmacies within the state. Thank you. Next slide. I think that's the last slide. I'll take questions at this point.
George, there's quite a few. Thank you. That was a great presentation, by the way. Let me just preface that by saying amazing. And welcome to everyone who joined us on Zoom a little bit late. So there's a few questions. I'm going to start with just a very broad question. A lot of these drugs are very new. There were exclusion criteria that kept vaccinated individuals, people who got monoclonal antibodies, from being in the studies. Do we have any sort of post-marketing data or any data on vaccinated versus unvaccinated response to any of these drugs yet?
No, I think that the groups that were doing these studies really wanted to try to enrich the populations as much as possible for benefit, right? So they were generally unvaccinated patients because they would be at highest risk for hospitalization and death. So we don't really have good data on what happens to vaccinated patients, although we know that the vaccine effectiveness wanes over time, especially if someone doesn't have a booster. And so at least within the state of Washington, for example, there's guidance of which vaccinated groups to administer these drugs to. Those would be the high risk. Those people that, for example, are very elderly or they can't mount an immune response, those people are included in state guidance. But the FDA EUA is very, very broad. And so and you can see what those are for each drug on the dot phrase. The dot phrase has a complete EUA criteria. Now, one should also be aware of what their local region is saying and what the state is saying, because they, like Washington, they also limit who they're recommending using these drugs in for trying to enrich for people that will benefit the most.
Very good. Thank you. Question about an alternative agent. Can you speak to the evidence that oral fluvoxamine decreases COVID morbidity and the need for hospitalization? Is it worth including in the list of ambulatory options?
That's a really great question. We did not review fluvoxamine. There is some data out there that it may be beneficial. There's also conflicting data as well that shows no benefit. The IDSA and the NIH currently say there's insufficient data for or against using fluvoxamine. The Antimicrobial Stewardship Committee met on Monday to discuss this very topic about, what to advise providers. And at the end of the day, the position was similar to the NIH and IDSA, that there's insufficient data to support or not recommend using this agent. Now, that being said, with these first 4 agents, in low quantities, we are not recommending against using it. We're not recommending for it. So if there are providers that want to provide their patients something and there's nothing else available, one can consider using this. But at least based on national and our health system guidelines, there's not a recommendation for or against at this point.
A flurry of questions now about fluvoxamine, which prompted the idea of budesonide inhalation. Any comments on that as part of the stable?
Yeah, and I think the same is, true for budesonide. I can't remember if we actually addressed the language for budesonide. I think we did, but it would be the same. That NIH, I believe, also indicates in their guidelines that there's insufficient data to support for or against the use of budesonide. That being said, at least when we talk about steroid use in patients, we do have large studies that were conducted looking at the use of steroids in hospitalized patients. And the more hypoxemia there was, the better that dexamethasone performed. There was still a benefit in people that were on low flow oxygen, meaning they were mildly hypoxemic, requiring usually between 2 and 6 liters by nasal cannula. There was a small but definite benefit there. However, in the cohort of patients that were not requiring oxygen, there was a non-statistically significant trend towards worse outcomes. And so at least with Decadron, we are clearly advising not to start it before patients are hypoxemic. And that was a very large study in the UK. So the budesonide data should be taken a little bit with a grain of salt, I think, as well. But again, neither recommended for or against.
Excellent. Moving into some specific medication questions. There was one around Paxlovid if it's prescribed and we see elevated blood pressure, do you just watch it or do you adjust the meds or what?
Yeah, it's a really great question. So I think that, the having to stop treatment, I think did not really occur very much. So if it's a mild increase in blood pressure with Paxil, I think it's okay to observe. Obviously, if it gets to a level that's concerning, that's very, very high, that would certainly warrant stopping it. But I think that the discussion about hypertension really needs to happen with the provider and the patient in terms of what numbers they're comfortable with, continue or not continue. Now, but the duration of treatment is fairly short, right? It's only a few days, and so they're off of it pretty quick.
Great answer, thank you. A couple of logistical questions. One, is there a need to stock up on at-home COVID-19 tests? Some patients are apparently a little concerned.
Well, I think that the COVID testing currently is in short supply. And, at this moment in time, it would be best to have them available for people who actually have symptoms. We know that these antigen tests are not very sensitive when someone is asymptomatic in general. So given the limited supplies that we have nationwide, it's probably best reserved for people that actually have symptoms and actually need testing rather than sit in someone's shelf at home.
Similar question around testing. Given the bottlenecks and possible shortage of testing in the very near future, is that an absolute requirement, especially for a medication like sofosbuvir?
Yeah, I think in order to dispense any of these agents, there must be a positive COVID result, and that's part of the inclusion criteria, that the patient must be COVID positive. So impaired treatment without testing, I do not think is warranted.
And does that testing, must it be PCR or would antigen suffice?
No, I think an antigen test would be sufficient to demonstrate that the patient is positive. I think that, as we're going through this current surge, there are going to be even more and more delays with PCR testing with longer turnaround times. And so I think that an antigen test would likely suffice in the right clinical scenario.
Very good. And this is great information. I'm sort of going through my head, like, how do I implement this in practice? There's a question around, will there be a training/education toolkit developed for clinicians to tie into the guidance, operational workflows? I mean, you've given us a lot of stuff out there. How to check retail pharmacies for inventory supply, how to know about shortages. I mean, how do we manage this?
Yeah, so it's a great question. And so I think that the people that are best positioned to advise each region is the regional pharmacy directors within each region. So for example, Sean Dobbin is the regional director for WAMET, and he's put together some guidance for our region that combines the directives from the state, a nice flow sheet for treatment that he's provided, and other resources. The allocations and inventory are going to be hard to know outside of our health system by our own pharmacy directors. That really needs to be solved by each state, because they're the ones allocating drug to outpatient pharmacies. And so each Department of Health at each state should provide information about where drug is allocated, and hopefully who has drug on hand, as the state of Washington is doing with their dashboard. So at least the state of Washington, there's going to be a website, Department of Health, that will show you where it is and whether or not they have drug at least once a day on hand.
Okay. There's a bunch of great specific clinical questions coming up now. Just quickly, can you comment about Viagra and or birth control pills in males? Two other things that have hit the press.
Viagra for treatment of COVID?
Yeah, I think there's some, since it's used for pulmonary hypertension, there's some indications that may help with lung injury.
Yeah, I haven't seen that data. So at this point, I think it would be very premature to try to use it. So the other sort of thing would be that we do have attached these, this meeting were the Providence Health System's treatment guidelines for COVID-19, and it reviews sort of all the available data on current treatments for outpatient, inpatient, as well as some recommendations for pre-exposure as well. So that we try to maintain up to date as much as possible, meeting basically weekly to get new drugs and treatments on there, as well as moving drugs around depending on the new data. So that is one of the attachments to this meeting invite. So I would encourage you to take a look at those treatment guidelines. They are, at least for within our health system, the most up-to-date reference we have.
Excellent, thank you. I think there's a question going back to an antigen test would be good enough to qualify for drugs. There's a question, can you clarify on whether there has to be a lab antigen test or would a home test suffice?
Yeah, that's a really good question. I mean, ideally it's done, within a clinic setting, but ultimately the attestation comes from the provider, right? So the provider is the one that needs to review the clinical data to determine if a patient qualifies, and they're the ones that attest to the positive assay. So they will need to discuss with their patient whether or not they feel that a home result is sufficient. And honestly, it probably is, but that's really part of the patient provider relationship, whether or not they want to count a home antigen test. And the ones that are in the labs are very similar tests anyway, so it may be sufficient.
Right. Okay, so here's a specific clinical question: a patient with COPD or asthma and COVID, would there be a reason to wait on starting prednisone until 5 to 7 days in, or use different steroids?
Yeah, I think that's a really good question about if someone has asthma and COVID, or COPD, and you feel that steroids are indicated for their underlying pulmonary problem, I would start it as you normally would. The usual doses of prednisone are much lower than the equivalent doses of dexamethasone we use in the hospital. So I would treat patients as you normally would. But again, many of these patients also qualify for these treatments as well. So if you can access one of these treatments for those people that are higher risk, that would certainly be worthwhile. Okay.
A great question on back to sort of the indications for use, trying to parse out the risk and benefit when it shifts for fully vaccinated and boosted individuals. For example, nursing homes are generally able to administer MAB monoclonal antibodies and remdesivir, but they have a highly immune population. Given resource constraints, should they be reserving treatment just for the unvaccinated despite having the elderly population, or how do you balance that?
That's an excellent question. And so, we don't have data that's that granular. And so if you're talking about, what the precise population is to treat, what you want to do is essentially find out, what risk factors result in the lowest number needed to treat, right? And so all we have right now really is the data that I presented on these papers, which was fairly broad. What we don't yet have is, of these risk factors or combination risk factors, we don't have a model to say, this combination of age, vaccination status, and past medical history results in your individual risk of, number needed to treat of 10, for example. So we don't have that data. I've spoken to Dr. Robichuk, who's the head of our research department at Providence. He felt we didn't quite have enough hospitalizations yet to really be able to model that. But that would be something that would be very interesting to do. I hope we can get to it where, we can provide with internal data, show, okay, these are what we're seeing in terms of risk factors and criteria for admission in all of these populations, and target those that are the highest risk.
Thank you. Great answer. I'm going to call on your crystal ball for a personal question. So we're in Omicron surge right now, and we're in a medication shortage. Which one's going to finish first?
Yeah, I think we're probably still going to be in the peak when the number of doses increases. So, unfortunately, right now these drugs are very scarce. But hopefully, within the next few weeks, we'll see an increase in availability of these agents. Hopefully, I think before the end of this surge, because we're anticipating this to peak in another about month, or so, and so hopefully by then we'll have a lot more availability of these agents. It's a little hard to know for sure.
I'm going to pause. If there's any more questions, please drop them in the chat. It's been a great presentation, great questions, wonderful answers. Appreciate you being here. I'm not seeing any additional questions. So I'm going to wait for just another minute. I think we've gotten through all of the questions that were asked. And so I will bring us to an end. So I will thank you, Dr. Diaz, once again for an excellent presentation. There's a new message. Yes, so Trovimab infusion time is 30 minutes, verified off the EUA healthcare practitioner sheet. So thank you very much again for a wonderful presentation. For those who showed up a little late, this will be posted on the recording, so you can go back and see the parts that you missed. Just one last question. Are there a lot of hospitalizations for Omicron right now? Short answer, yes. And you can check that on the surge page. So thanks again. Thank you, Dr. Diaz, and we will close.
Thank you, everybody.